Thank you, Lisa. Thank you, the Duchenne, for this opportunity to present this data to you today. I'm gonna make it less scientific heavy because at times I get carried in my head and I'm excited about data. So I'm gonna try to not be excited, right? And thank you to all the speakers because I think they've made it easier for me to come and talk, right? Lisa did an amazing job and Catherine did an amazing job to talk about how we get therapy into the muscle. And I'm just gonna follow through with that. So today I'm going to talk about the disorder, which is a molecular clinic. And this is an initial data that we had from a clinical study known as Explore 44. Um, okay. We are a publicly traded company. Please don't try to read that because you might spend a whole day. I'm just going to flash that and move on. We want to actually profoundly thank everybody, especially the patients and caregivers and providers, right? Because our vision is to profoundly improve people's lives, and we do this by using RNA technology to revolutionize how we deliver RNA therapeutics. And we are here today. The data I'm going to show and present, we need to acknowledge that we are here today and where we are is because of everyone and the patients and community, and together with them, we are able to make a stride in this field today. So great. Our platform is called antibody oligonucleotide conjugate. It's a mouthful, so we call it an AOC. And just like Catherine mentioned, we have three components to the AOC. We have the antibody, we have the linker, and we have the oligonucleotide. That's the PMO. So the antibody portion kind of serves as the navigator, right? It kind of makes sure that we deliver payload, the PMO, into the muscle. So the drug, we called it AOC 1044 for a long time, but now it has a name. And the generic name, which I will struggle, and please don't laugh because it's not funny, is called Deripacibat zotadiceran. But then we realized that that is not even feasible anymore. We call it Delzoda, which I think is a little bit better and not as heavy in the mouth. So a little cartoon as how does Delzoda work? So it's a three-part molecule. We have the antibody portion, as I mentioned. We have the oligonucleotide and with the linker. So as Catherine mentioned, we are taking advantage of the transferrin receptor because it's highly expressed in so many muscle cells. So what happens is that the antibody portion would bind to the transferrin receptor, like the cartoon, the first part. You see where it says a muscle cell and inside the muscle, and then that will aid in the transportation of our payload into the muscle. And then we see that the oligonucleotide, the orangey red part, is released, and that is what goes in the nucleus. And this is specific for those boys that are amenable to exon 44. So like in the cartoon, we could see that it binds on the 44 part, results in the skipping, and then we have the cartoon below that then increase our dystrophin production. So in a high level, that is what we are trying to achieve with Delzoda. So let's look at the data. And before we start, some of the key information of this trial is that we did what Alisa said and what Catherine said, we did a multiple ascending dose. And then we had 24 boys. The age was 7 to 27. And we had both ambulant and non-ambulant boys, and we required biopsies in our cohort. And then everybody that's the trial right now would extend because we have a placebo arm. But at the end of the trial, everybody gets a drug. Primary objective, like we heard yesterday in the phase 1-2 trial, is to see how safe and how this drug is tolerated in the community. And then we had a couple of secondary objectives: pharmacodynamics, pharmacokinetics. We looked at exon skipping as well as dystrophin protein levels. And then we are looking at measures of muscle function, and then patient-reported outcome, and of course, quality of life. So this is how the design looked like. We started off with healthy volunteers just to make sure that we have a safety profile. And that was part A of the study. That was completed a long time ago. Then we moved on to part B. Now that was with Duchenne boys. And we had two cohorts. The first part was 5 mg per kg, and that's the result I'll be presenting today. That cohort is enrolled and complete. And then we have a second cohort that is 10 mg per kg that is actually ongoing. And this was randomized 3 to 1. And this is based on demographics. Just to call attention, we had a placebo arm and we had the treatment arm. And right now, the data cut was done with 12 patients. So our creatinine kinase was average around 7,000 and 5,000 for both arms. Everybody could still use corticosteroid while on trial. And then age of symptom onset was average around 3.8 years old. Safety profile, we had no treatment emergent effect. We had one participant that discontinued because of anaphylaxis and it was fully resolved, but the physician felt it safe for them to discontinue. And then we had one patient that discontinued because of an infusion-related reaction. But as of now, we saw no symptoms of hemoglobin changes or hypomagnesia, as well as any renal events that was a cause for concern. So, data right now. Let me just redirect your attention to the y-axis where it says PMO. That is looking at the amount of the payload that we have in the muscle. And then on the x-axis, we see we have two different colors. I might be colorblind, I'm sorry. I think it's teal and dark green. So please just entertain me with that. So yeah. So when it says a single dose HV, those are healthy volunteers. So they had one dose. And we're looking at a single dose, how much of the antibody or the oligonucleotide did we get into the muscle. But then when we look at our patients, right, the boys that live with Duchenne, they had 3 doses. And in this study, we dosed them 6 weeks apart. And we can then for sure confidently say that from this graph, from those patients as well as healthy volunteers, we average over 200 nanomolar of the oligonucleotide in the muscle because delivering the muscle had been an issue. So it was an internal control for us to make sure that we're achieving that delivery. So fast forward, this is results now. On the y-axis, we're looking at percent exon skipping. On the x, we're looking at 2 different groups, right? The gray is the patients that were on placebo. So we can see that at baseline or at 4 months when we had the data cut, the level of exon skipping was not significant. It just stays the same. But if we look at those patients that were on Delzota at baseline and compared to 4 months or 5 mg per kg, we actually can appreciate that we have a 37% absolute increase of exon skipping. And there was a patient that actually had a 66% increase in exon skipping. So that was really exciting to see. And how does that translate to dystrophin? Because I think if you say exon skipping, you want to make sure that you have dystrophin production. So same kind of layout where on the y-axis, we're looking at the dystrophin production. And then on the x-axis, we're looking at both groups, the placebo group as well as the active arm. Yet again, if you look at the placebo group, both baseline and at 4 months, we don't see any change. But then when we look at the treatment arm, at 4 months and at baseline, we see an absolute increase of 25% of dystrophin production. And we had another participant that averaged up to 54% increase. But then if we look at the cartoon to the far right, to my right, I think it's your left, we want to appreciate that from a DMD perspective to a healthy individual, there is a spectrum, right? So we're thinking about with an absolute 24% increase, where do we sit in that spectrum? And we can see that from a 7 to a 32% increase, that is what we extrapolate from our graph, that gives us a 25% increase on those order. And that is already getting you to a point where you sit where the healthy individuals start. Hence, this just gives us more excitement about this molecule, right? That we can see this much increase that can get you almost close to where a healthy individual kind of sits at. And then we look at creatine kinase, right? Because we know that muscle injury, there's increase of creatine kinase. And we can appreciate that for those boys that were on active Delzota arm, there is a reduction of creatine kinase to almost upper limit of normal. And if you look at the boys that were on placebo arm, they still have a really high increase of creatine kinase. And if you compare that to baseline, it kind of averages up to like 80% of creatine kinase reduction. So I know I've said a lot about data. Please take just this 4 home, if that's all you could take, right? We did show that we could deliver Delzota to the muscle. And then we also showed that we had a significant increase of exon skipping that resulted to a significant increase of dystrophin production, and that was accompanied by a decrease in creatine kinase biomarker. So what's next for us right now? With this data, we do understand that comes a lot of responsibility, because at the end of the day, we need to get this to patients. We need to get this to the boys with Duchenne, right? So right now, our focus is to make sure that we complete the study, the Export 44 study, and gather the data package that we need to support an approval in the US. Unfortunately, I know we're in Canada, we always have to start in the US, right? And then we're also looking, we are currently to look at interactions with regulatory body right now to see how we can identify the best path forward to get the drug to the patient. But then, even though we're currently focused in the US right now with regulatory discussion, that does not limit us in our global plan forward. So at Avidity, we always come together every quarter. Everyone in the company comes together because we want to remind ourselves why we do what we do. And for that, we want to really extend our gratitude to you, Lisa, and to the community, because the partnership we've developed has allowed us to make progress that we can share with everyone today. So thank you all so much for your patience.